At the EHA 2020, we present an update of the MASTER study. So the MASTER study is a trial for patients with newly diagnosed multiple myeloma that combines the proteasome inhibitor carlfizomib, the immunomodulatory agent lenalidomide, the monoclonal antibody anti-CD38 daratumumab, and dexamethasone. This trial, what is unique about this trial is not only this quadruple combination, including with carfilzomib being used on a weekly schedule, but also the fact that we use MRD assessment, not only as an endpoint, but also to determine duration and intensity of therapy. So all patients receive 4 cycles of Dara-KRd induction. They have MRD assessed at the end of induction. They receive autologous stem cell transplant. They again have MRD assessed. And patients who have 2 consecutive MRD below 10 to minus 5, so at the end of induction and at the end of transplant, go on to observation for something that we call treatment-free observation and MRD surveillance, or TREFONS for short. The patients who do not meet that criteria yet, they go on to receive up to 2 blocks of 4 additional cycles of Dara-KRd, again with MRD assessed at each block, and again at any time where the patient meets criteria for 2 consecutive MRD below 10 to minus 5, they transition to TREFONS. So the study has, at the time of the data cut for the EHA abstract, the study had accrued 101 patients. Of those patients, 19% were ISS stage 3, and 29% of the patients had high-risk chromosome abnormality, including 17p, 414, and 1416. We assess MRD by clonoSEQ. Therefore, we could report not only MRD to 10 to minus 5, but also could report MRD to 10 to minus 6. At the time of the data cut of those 101 patients, the vast majority of the patients had responded, and 91% of the patients had reached VGPR or better after induction. Post-transplant, 92% of the patients had a complete response or better using traditional response criteria. In terms of MRD, the rate of MRD below 10 to minus 5 was 42% post-induction, 73% post-transplant, and 82% using MRD-guided post-transplant consolidation. When you look at 10 to minus 6, those rates were 28%, 50%, and 63% respectively. The trial continues to accrue and with some enrichment for high-risk chromosome abnormalities, which in the long run will allow us to have a better understanding of how this combination, how this approach work for patients with high-risk cytogenetics. At the time being, however, the rate and depth of response seems very different between standard risk and high-risk patients. For instance, the rate of 10 to minus 5 reached on the study was 83% for standard risk and 79% for high-risk patients. The study evidently has some toxicities, particularly considered that we enroll patients with a pretty liberal set of criteria compared with other transplant-eligible trials. For instance, we didn't have an age limit, and patients who present with a high disease burden were allowed to be included after, for example, 1 cycle of bridge therapy to overcome, for example, hypercalcemia or renal failure. All in all, we have had the most frequent adverse events have been cytopenias and infections, including 1 case of fatal metapneumovirus pneumonia. Perhaps the most fascinating aspect of this study is we're essentially creating a cohort of patients who have a deep response with MRD negative, early and deep response that are being observed off maintenance therapy and with MRD surveillance. So at the time of the data cut, we had 40 patients we had transitioned to this we call TREFONS phase. And of those 40 patients with a follow-up between less than a month and 15 months, none of the patients had had a progression or had had resurgence of MRD. So we believe the studies are, these preliminary results are very promising. And of course, we look forward to learning from a longer follow-up, particularly on how, what the kinetics would be of MRD resurgence among those patients who are off therapy.